Welcome to this masterclass on mastering the nursing care plan. After understanding the nursing process, it is crucial to understand how to properly develop a plan of care for your patients. In clinical practice, the care plan serves as the core foundational roadmap for all patient care. It translates complex medical data into individualized, structured, and highly effective nursing interventions. Notice the overarching framework highlighted at the top of our care board, ADPIE. Assessment, diagnosis, planning, implementation, and evaluation. As the core axiom states, a good care plan is the bridge between thorough assessment and high-quality patient outcomes. When we examine what constitutes excellent care planning, several key criteria must be met. First, it must be patient-centered, tailored specifically to the physiological, emotional, and social needs of the individual sitting before you. Second, it must be evidence-based, grounded in validated clinical guidelines and research rather than guesswork. Third, it is goal-directed, meaning every action taken is aimed at reaching a measurable, realistic therapeutic target. Fourth, it must be individualized, acknowledging that no two patients experience illness in the exact same manner. Fifth, meticulous documentation is non-negotiable. If an intervention or observation is not documented, clinically it did not happen. And finally, a care plan is a living document. It must be continuously reviewed and revised as the patient's condition evolves. Look closely at our clinical mascot at the bedside. Observe how detailed bedside assessment forms the direct basis of every entry written on that clipboard. As we journey through this guide, keep this bridge in mind. Every diagnosis, goal, and intervention exists to push the patient safely across that bridge toward full recovery. Let us analyze the systematic care plan formula. This sequence is the operational backbone of nursing methodology. Step 1 is assessment, where subjective patient statements and objective clinical measurements are gathered. Without accurate baseline data, the entire formula collapses. Step 2 takes that data and synthesizes it into a standardized nursing diagnosis, identifying actual or potential health problems using approved terminology like NANDA. Step 3 formulates the SMART goal, specifying precisely what measurable patient outcome we expect to achieve and within what time frame. Step 4 establishes the nursing interventions, the deliberate, evidence-based actions nurses perform to address the diagnosis and achieve the goal. Step 5 provides the scientific rationale, answering the critical question, why does this intervention work physiologically or clinically? And finally, Step 6 is evaluation, systematically measuring the patient's actual progress against our initial SMART goal to decide whether to resolve, modify, or continue the plan. Notice how every step logically links to the next. Assessment informs the diagnosis determines the goal dictates interventions, rationales validate interventions, and evaluation closes the clinical feedback loop. Before writing a single word of your plan, you must master the mechanics of data collection and action categorization. Look at the left sidebar under Assessment Tips. Assessment relies on systematic physical examination and clinical inquiry. We observe general appearance and behavior. We interview to gather personal history and symptom narrative. Then we execute physical assessment techniques in strict order, inspect visually, palpate for structural abnormalities or tenderness, percuss to determine tissue density, and auscultate heart, lung, and bowel sounds using your stethoscope. Furthermore, we review laboratory and diagnostic investigations, and crucially, validate patient data to ensure subjective complaints match objective physiological findings. Now, moving down to the types of interventions. Nursing actions fall into 3 distinct regulatory categories. First, independent interventions. These are nurse-initiated actions performed autonomously within the legal nursing scope of practice, such as patient repositioning, skin assessment, or teaching deep breathing techniques. Second, dependent interventions. These require an explicit physician's order or prescription, such as administering 4 medications, ordering diagnostic imaging, or applying supplemental oxygen beyond standard protocols. Third, collaborative interventions. These are interprofessional actions coordinated with physical therapists, dietitians, pharmacists, or occupational therapists. Understanding these distinctions ensures legal compliance and clinical clarity in your documented care plan. Let us apply our formula to a practical clinical scenario, a patient presenting with acute pneumonia. Look at Section 1 of our care plan matrix, Assessment Data. Notice how assessment is divided into two distinct categories, subjective and objective. Subjective data consists of unmeasurable, personal complaints spoken directly by the patient. Direct quotes are best practice here. Our patient states, "I have difficulty breathing. I have chest pain, and I feel very tired." These symptoms indicate dyspnea, pleuritic discomfort, and systemic fatigue. Now look below at the objective data. These are measurable, observable physiological metrics collected by the nurse. The patient's respiratory rate is tachypneic at 30 breaths per minute. Oxygen saturation is critically compromised at 88% on room air. Auscultation reveals adventitious crackles in the lung fields due to alveolar fluid accumulation. A productive cough is present. Body temperature is elevated at 38.8 degrees Celsius, signaling systemic infection. Heart rate is elevated to 110 beats per minute, representing compensatory tachycardia, and physical examination shows active use of intercostal accessory muscles for respiration. Take note of how objective data validates subjective complaints. Elevated respiratory rate and low pulse oximetry directly confirm the patient's subjective feeling of dyspnea. After we have collected and validated assessment data, we move to Section 2, formulating a standardized NANDA nursing diagnosis. A clinical nursing diagnosis is not a medical diagnosis like pneumonia, rather, it is the patient's physiological response to that medical condition. A formal NANDA diagnostic statement follows the classic PES format: problem, etiology, and signs or symptoms. Look at our exact entry. The core problem is impaired gas exchange, defined as an actual excess or deficit in oxygenation and carbon dioxide elimination at the alveolar capillary membrane. Next comes the etiology, connected by the phrase related to. Here it is related to alveolar inflammation in infection. This pinpoints the pathophysiology. Infectious exudate fills the alveoli, creating a diffusion barrier. Finally, we attach the supporting evidence, connected by the phrase as evidenced by. Here we explicitly list our clinical findings, as evidenced by SpO2 of 88%, difficulty breathing, dyspnea, elevated heart rate, tachypnea, crackles on auscultation, and use of accessory muscles. This precise linkage ensures that anyone reading the diagnosis understands both the underlying etiology and the physical evidence justifying the clinical prioritization. To build clinical efficiency, nurses must become intimately familiar with standard NANDA-approved diagnostic categories. Look at the summary reference card on the right. These represent 10 of the most frequently encountered diagnoses across medical surgical settings. First, acute pain associated with tissue trauma or biological injury. Second, impaired gas exchange seen in respiratory distress, pneumonia, or COPD. Third, risk for infection vital for surgical patients or immunocompromised states. Fourth, deficient knowledge applied when patients require disease management education. Fifth, activity intolerance, characterized by insufficient physiological energy to complete daily activities. Sixth, ineffective airway clearance, the inability to clear secretions to maintain a patent airway. Seventh, risk for falls, crucial for safety management in elderly or confused patients. Eighth, imbalanced nutrition, less than body requirements. Ninth, anxiety, addressing emotional and psychological distress. And 10th, fluid volume deficit, vital in dehydration, hemorrhage, or severe vomiting. Mastering these standard diagnostic titles enables rapid, accurate, and standardized communication across the entire healthcare team. With our diagnosis clearly stated, we step into Phase 3, planning SMART goals and expected outcomes. Examine the green SMART framework box on the right. Every outcome objective must strictly adhere to these 5 parameters. S for specific, clear and precise about the desired change. M for measurable, observable and quantifiable using concrete metrics. A for achievable, clinically realistic for this patient's condition. R for relevant, directly pertinent to resolving the underlying primary diagnosis, and T for time-bound, bound to a strict, defined evaluation window. Now look at our pneumonia care plan entry. Notice the temporal anchor, within 24 hours, the patient will. Followed by 5 explicit, measurable targets. First, maintain SpO2 above 94%. Second, report easier breathing. Third, demonstrate improved breath sounds upon lung auscultation. Fourth, maintain a normal respiratory rate of 12 to 20 breaths per minute. And fifth, remain entirely free from respiratory complications such as atelectasis or respiratory failure. Notice how every objective directly opposes an abnormality found in our assessment data. Low oxygenation becomes oxygen saturation above 94%, tachypnea becomes 12 to 20 breaths per minute. This tight symmetry is what makes a care plan clinically powerful. We now enter implementation and rationale mapping. Columns 4 and 5. Nursing interventions must never be arbitrary actions. Every single intervention requires a direct, evidence-based scientific rationale explaining why it works. Let us walk through all 10 clinical pairings. Item 1. Assess respiratory rate and pattern. Rationale: detects early physiological deterioration. Item 2. Monitor oxygen saturation via continuous pulse oximetry. Rationale: evaluates the real-time effectiveness of cellular oxygenation. Item 3. Administer supplemental oxygen as prescribed. Rationale: directly increases alveolar oxygen pressure and improves systemic oxygen delivery. Item 4. Position patient in high Fowler's position. Rationale: uses gravity to pull abdominal organs down, maximizing diaphragm descent and enhancing lung expansion and ventilation. Item 5. Encourage effective coughing and deep breathing exercises. Rationale: mobilizes retained bronchial secretions and promotes airway clearance. Item 6. Encourage increased oral fluid intake. Rationale: liquefies thick pulmonary secretions and prevents systemic dehydration. Item 7. Administer prescribed for or oral antibiotics. Rationale: directly targets and eradicates the underlying bacterial pathogen causing infection. Item 8. Monitor body temperature routinely. Rationale: evaluates pyrexic trends and systemic response to antimicrobial therapy. Item 9. Assess sputum characteristics including volume, color, and odor. Rationale: indicates infectious severity and guides targeted antibiotic adjustment. And Item 10. Educate the patient regarding rest, hydration, and medication adherence. Rationale: reduces baseline metabolic oxygen demand, promotes cellular recovery, and prevents illness relapse. Linking action to physiological rationale ensures critical thinking at every step of care delivery. Step 6 brings us to implementation. Implementation represents the active execution of our care plan. Look at the header prompt. Notice the strict grammatical rule shift. While interventions are planned in future tense, implementation is documented exclusively in past tense, detailing exactly what was delivered to the patient. Review the clinical documentation records. Respiratory rate was assessed every 4 hours. Oxygen saturation was monitored regularly. Oxygen was administered at 3 liters per minute via nasal cannula as prescribed. Patient was positioned in high Fowler's position. Coughing and deep breathing exercises were demonstrated and encouraged. Fluid intake was encouraged and recorded. First dose antibiotics were administered as ordered. Temperature was monitored every 4 hours. Sputum was assessed, noted as moderate in volume and yellowish in color. Patient was educated on rest and the vital importance of completing the full course of prescribed medication. In nursing jurisprudence, accurate past tense documentation provides legal and clinical proof of care delivered. The final step of the care plan process is evaluation. Column 6. Evaluation is not simply checking boxes, it is a formal reassessment to determine if our SMART goal was successfully achieved. Look at the explicit criteria for goal achievement. The goal is deemed fully achieved when SpO2 is maintained at or above 94%, respiratory rate normalizes to 12 to 20 breaths per minute, the patient explicitly reports easier breathing, lung auscultation reveals improved or clear breath sounds, and 0 pulmonary complications have occurred. At the end of our 24-hour timeframe, the nurse selects one of 3 definitive clinical outcomes: goal met, goal partially met, or goal not met. If the outcome is goal met, the specific nursing diagnosis may be resolved. However, if the goal is partially met or not met, the nurse must immediately reassess, identify barriers to recovery, modify interventions or timeframes, and continue systematic evaluation. The care plan is never static. Evaluation ensures continuous adaptation until full health is restored. To conclude this masterclass, let us summarize the core gold standard principles for clinical practice and board examinations. Examine our lower mastery panel. Under Nursing Pearls, remember these fundamental rules. Assessment always comes first, never jump to conclusions without physical data. Base every diagnosis strictly on validated assessment findings. Ensure all goals are measurable and patient-centered. Never write an intervention without knowing its underlying scientific rationale. Systematically evaluate every target, and immediately modify the plan when goals are unmet. For students preparing for exams in our Exam Corner section, memorize the ADPIE steps, master NANDA formatting, write precise SMART goals, pair interventions with physiological rationales, and maintain meticulous documentation. Finally, memorize the cardinal golden rules posted on our clinical sticky notes. Assess before you act. Diagnosis comes directly from objective assessment, never from assumptions. If it isn't documented, legally it was not done. Patient-centered goals drive superior recovery outcomes. Evaluation dictates your next clinical move. And above all, think critically before you write. As shown in our footer banner, remember, you are never alone in your clinical journey. By applying these structured principles, you will deliver exceptional, evidence-based care and achieve superior patient outcomes every single day.